How many people in this room have a close relative, mother, father, sister, brother, husband, wife, who has had cancer? Child. Everybody in the room. So I'm going to leave you with Dr. Joe, and thank you so much for your attention this afternoon.
Thank you, Dr. Mitchell. After the working lunch and these exciting presentations, I am sure that nobody will suffer from itis simply because of the topics that we have to discuss. It's always surprising that we find out data concerning numbers that we don't know. Just as recent as an hour or two ago, we heard numbers concerning cancer and cancer screening in the African American community that were just appalling, and we thought we were on top of this. But the numbers are important. We have to begin to reduce a lot of what we do in medicine to numbers more than what we have done in the past. I would not change your blood pressure medication without knowing what your numbers are. I would not change your insulin or your diabetic treatment without knowing what a fasting, a 2-RPC is, A1C. We're going to reduce this to numbers, and we have to do that in our approach to screening and prevention in cancer as it relates to primary care physicians, but also as it relates to everybody. So to start the second portion of this afternoon's program off is Dr. Richard C. Wender. Dr. Wender is president of the American Cancer Society in Atlanta, Georgia. Richard.
Thank you, and I do have some slides that we can bring up. There we go. Well, thank you so much. It's quite an honor, and I'm humbled to be able to join this colloquium, and I was looking so forward to speaking to the group until we had to end the previous group. I think I would have rather just kept going with that, but you know, they are so tied together because what our communities are like impacts every one of these health issues. In 1996, the American Cancer Society issued a challenge goal to the nation to reduce age-adjusted mortality from cancer by 50% by the year 2015. Well, obviously 2015 has come and gone, and in just a month or two, we will publish the final report from this 2015 goal, and there's a glass half full, a glass half empty. We actually made it slightly over halfway to this goal, a 26% reduction in age-adjusted mortality. And you'll be interested to learn the highest percent mortality reduction was in African-American men. Right behind it, African-American women. However, as you also know, there are areas of true failure. In this period of time, the disparity, for example, between African-American women, European descent women, has actually grown each year for breast cancer mortality. So lots of areas of disparity reduction, but one or two areas of increase. We know how this has happened. A dramatic reduction in lung cancer deaths in men due virtually entirely to a reduction in smoking. A dramatic reduction in both colon cancer mortality due to screening and prostate cancer mortality. And of course, African American men are at the highest risk in the world for prostate cancer. And we've seen a dramatic reduction, now seeing mortality rates last seen in the 1930s. Breast cancer, 7 years after mammography recommendations from the ACS, mortality in women started to come down for breast cancer. We're finally turned the corner in lung cancer, and colon cancer deaths continue to go down. So if you really look at the areas of progress, they are in the areas for the cancers that we can prevent and the cancers that we can detect early. We have seen very little, often no progress, in cancers for which we don't have a prevention or early detection approach. So we now, as we look forward beyond 2015, have to build a foundation that will accelerate progress, and I believe this is that blueprint. We must prevent more cancers. We must find more cancers early. We must continue to find new treatments and cures, but perhaps more importantly than all of these things, we must advocate for everyone to have an equal chance to benefit from these advances. Today, we're just talking about two of them, and I'm going to give you a broad overview: prevention, early detection. We have already uttered this phrase a number of times at this conference: zip code is more important than genetic code, and it's a fact. There is no single genetic mutation that accounts for as much disparity gap in mortality, including cancer, as where you live. And all of the organizations you're going to hear from today are committed to creating healthier communities in partnerships with the folks who live there. Let's talk about tobacco control. We've had enormous progress. Many people don't realize that adult smoking rates are now down to 15.7%, under 10% in teens, which just a few years ago we thought would be impossible. But we simply cannot celebrate these important advances because there are still 45 million smokers as well as cigar users, 480,000 tobacco-related deaths every year. And although we've seen this huge decline, rather precipitous decline actually, in smoking in youth, we've seen a skyrocketing increase in the use of e-cigarettes and vaping. They virtually are crossing each other and certainly are related to each other, so we're going to have to understand what that means. We need new disruptive strategies for tobacco. Perhaps the most exciting is Tobacco 21. Hawaii, New Jersey, the city of San Francisco just 2 days ago have raised the legal limit to buy a pack of cigarettes from 18 to 21. We need to see that spread all around the nation. Reducing sales outlets, such as was done in CVS, creating smoke-free educational and workplace campuses, not just on colleges where we're doing a lot of work, but smoke-free campuses at the high school level, which would be extraordinary. We need to continue to increase the price of a cigarette. That is the single most effective intervention, and figure out what the proper, if there is, an appropriate spot for e-cigarettes and vaping. One of the reasons we've kind of pushed tobacco aside a little bit as a problem is because today's smokers are not powerful in society. They're largely invisible. They're individuals with mental illness, institutionalized individuals, Native Americans, people living in poor rural areas, long-distance workers who travel across long distance, such as truckers. And as a result, their voice is not always heard. Healthy eating and active living. 85,000 U.S. cancer cases per year are related to obesity, and if we do not reverse the obesity trend, we'll see a huge contribution to future cancer cases in just the next 15 years. The approach to this can no longer be just eat better and exercise more. We are going to have to alter the environment in which people have the opportunity to make choices. Healthy food, the opportunity to exercise must be available equally in every community. We have new opportunities to prevent cancer, HPV infection, and disease. In women, 17,600 new cancers per year related to HPV, mainly of cancer of the cervix, but others as well, and about 10,000 cancer cases a year, HPV related in men, mainly oropharyngeal cancers, but a few others as well. We now have a vaccine that can prevent HPV infection. We know it's effective in cervix cancer prevention. It's likely to be effective in these other cancers. We believe we can largely eliminate cancer of the cervix and substantially reduce cancer of the mouth and throat. At ACS, we have $8 million of new CDC grants to try to promote HPV vaccination. And together, I believe we can accomplish that. Right now, the vaccination rate in adolescent girls, all three vaccines, 36%. In boys, 19%. In the country of Rwanda, 98%. I believe we can do it in the United States. Number two, so that's prevention. Let's talk about finding more cancers early. I believe that there has been a systematic undervaluing of cancer screening, and there's a scientific reason for this. Randomized trials of cancer screening always will underestimate the disease-specific mortality reduction that results from screening, and here's why. When you do a randomized trial of screening, you actually are not comparing people who get screening to people who don't. They're trials of invitation to screening. So some people in the control group actually get screened, and some people in the invitation group do not get screened, and so that dilutes the effect. The number of rounds of screening is quite limited. For example, in the National Lung Screening Trial, the people in the intervention group got a CT scan at time 0, at 1 year, and at 2 years. They got 3 scans in 2 years, and then they were followed for the next 10 years. So we're really measuring the effects of only those 3 scans, not a program of screening over many years. The follow-up period, particularly for breast and prostate cancer, which may take a very long time to result in death, is often too short in trials. We see continued benefit reduction out 20 to 25 years from randomization, but if they are only followed for 10 years, much of that benefit is missed. Finally, randomized trials, just by reality of how a trial has to be done, are not the test of modern-day quality and technology. They were no more is this true than in breast cancer trials, where the most recent randomized trial in the United States was initiated over 40 years ago. That's not the mammograms that we're using today. So how does this manifest when we look at the value of screening and how we look at evidence? The place we know this the best is in mammography screening. So the estimates from the meta-analyses of the randomized trials tell us that we could reduce mortality by 20%. But there are many modern-day cohort and observational trials done all around the world. One of the most recent in Canada, comparing people through the National Canadian Screening Program who were screened to those who were not, who show reductions of 40 to 45%. So I do believe that screening plays a critical role. So here are the cancers we can screen for today. I think we're going to need to figure out how to screen for some others. One of the biggest targets I would put into place, by the way, is pancreas cancer, now the 3rd leading cause of cancer-related death in the United States. Cervix cancer, Pap smears with HPV co-testing. Breast cancer, mammography. Colon cancer, there are a number of modalities, but mainly it's colonoscopy or high-sensitivity annual stool blood testing, such as the FITs. Lung cancer with low-dose CT scanning. Prostate cancer with PSA. I'm going to make one slide of tips for each of those. Let's talk on cervix cancer screening. All screening now begins at 21, no matter when a woman initiates sexual activity. Every 3 years with PAP only from 21 to 29, and then every 5 years with PAP and HPV co-testing from 30 to 65. It is time to stop doing annual PAP smears. We have to put far more energy into reaching the women who have never been screened, rather than bringing women back annually, year after year after year, to do a test which every organization in the world agrees is not necessary every year. Breast cancer screening tips. There's far more agreement than disagreement, no matter what the press might communicate. All women should have the opportunity to have regular mammography from age 40 onward. Every guideline agrees with that. All women, if they haven't started in their 40s, should have started screening by age 50 at the very latest. The ACS recommends that the age at the very latest that a woman should start is 45. Colon cancer screening tips. There's the same mortality reduction achieved with any of the recommended screening methods, assuming that you achieve 100% adherence. Big assumption. Colonoscopy quality varies. The phrase that colonoscopy is the gold standard just is not true. There's enormous variability in colonoscopy, and it's not available to everybody in the United States. The good news is screening with a high sensitivity stool blood test every year with colonoscopy for positives, if we can deliver it as it's being done in the VA, Kaiser Permanente, great organized programs of screening can prevent the same number of colon cancer deaths. We're in the midst of a huge national campaign called 80 by 18 to achieve 80% colon cancer screening rates by the end of 2018. We would love to have the National Medical Association really be a leader with us in achieving this. Here are the numbers. If we achieve this goal, we will prevent 277,000 cases of colon cancer. We'll prevent 203,000 deaths from colon cancer. And we'll do that all in the next 15 years. That's 1 million colon cancer deaths prevented by the turn of the century. Colon cancer would be about the 6th or 7th most leading cause of cancer-related death in the United States, whereas today it's number 2, and it does not need to be. Lung cancer screening. Currently now recommended only for those people at very high risk, such as a 30-pack year smoking history or some equivalent contribution to risk. but it demands strict adherence to quality measures, including shared decision-making. Shared decision-making is now recommended for 3 different cancers for screening: prostate, lung, and part of the age group in mammography. So we're going to have to learn how to have those kind of dialogues with our patients that really allows them to tap into their own values. But the good news is at least a 20% mortality reduction seen in the trials, and I'm confident that in actual screening, we'll see even more than that. Prostate cancer screening, only in the context of a shared decision. As you may know, the United States Preventive Services Task Force no longer recommends prostate cancer screening, but I'm deeply concerned about that. Because we've seen an extraordinary decline in the United States from prostate cancer mortality, more than in any other country in the world. We have many individuals, mainly, of course, African-American men, at very, very high risk. The big issue here is overtreatment. Many of these men with early prostate cancer do not need aggressive treatment. The more that we can help our patients be comfortable with an active surveillance, the better we can provide true value with screening, rather than just not offering screening at all. 2 emerging strategies in this very broad, rapid overview. Aspirin. Aspirin prevents cancer. We now know with certainty that it prevents colon cancer, and there's pretty good suggestive evidence, we're still looking, that it reduces risk from other cancers like pancreas, breast, and lung. So I think we're underutilizing an 81 milligram aspirin a day. It's a great strategy. Finally, last but not least, is hepatitis C. If you were born between 1945 and 1965, you need a one-time screen for hepatitis C because we now have treatment for hepatitis C. But I so appreciated the panel this morning about making that treatment available because, as you know, the cost issues for hepatitis C treatment are significant. The good news is there is progress being made on price, and I believe we can make this more widely available. Liver cancer, now the 5th leading cause of cancer-related death in America. And for those of you who have either the same amount of gray hair or lack of hair, whatever it may be, as I do, when I was in medical school, we were taught liver cancer, you'll never see liver cancer. It's now the 5th leading cause of cancer-related death in the United States. So why are we screening particularly this age group, the baby boomers? And that's because we were all party animals. This is due to the era of free sex and drugs and, freedom. But we had a lot of hepatitis C to show for it, unfortunately. So we are not going to do this without an extraordinarily broad coalition to even imagine that we can accelerate progress as we envision is not possible without partnerships with groups like the National Medical Association. Thank you so much for inviting me.
Thank you. A message that still we can't get out properly. Our forefathers conducted a civil rights movement in this country when most people did not have phones in the home, televisions, but somehow the word got to the community at the level that it really needed to get there to be effective. We've got Twitter, email, Ditter, all kinds of stuff that we do, and we still can't get the message out. We talked about this a little earlier in the hallway about how we're spending the advertising dollar, and now we're going to bring up Dr. Judith Salerno, who is the Chief Executive Officer of the Susan G. Komen Cancer Foundation, Dallas, Texas, and I hope she talks about our failure to communicate.
Thank you very much. Well, it's a great honor to be here today. I was delighted when I got the invitation. I had met Dr. Edith Mitchell during some of our disparities roundtables that we were doing around the country. And when I heard the name of this meeting, True North Toward Healthcare Equity, I was really surprised, astounded, and pleased because after my first year, I've been at Komen for 2.5 years now. After my first year, I did an assessment of where our organization needs to take a leadership role. And at the end of that piece that I wrote, I said, and health equity was the top priority for our organization. And I said, this is our true north. So our organizations are on the same page. And every person here has a role in making this happen to help get rid of those obstacles that prevent us from getting to true north. My organization is Susan G. Komen is the largest breast cancer organization in the world, and for years we've worked on a lot of fronts to prevent and treat breast cancer. We are the largest breast cancer research funder outside of the U.S. federal government, and we have worked diligently in all our communities to remove the obstacles that prevent people who face cancer diagnosis from getting the care they need, regardless of their race, their location, or their socioeconomic status. We at Komen like to say that where you live should not determine whether you live. And when I saw the numbers when I went to Komen, and I was really astounded at the large gaps between African American and white women in breast cancer outcomes. We convened a number of roundtables. Well, first thing we did is we identified the 10 cities in the U.S. where not only were there highest mortality rates from breast cancer, highest disparities gap, and the most number of late-stage diagnoses. We knew we had work to do in those communities. So we've convened a series of roundtables. We're going to each of those cities to engage with the communities, to talk with people there, to bring community leaders together, whether they be political, healthcare, community organizations, faith-based communities, to talk about this problem and to own the problem and be part of the solution, and we will work with them. So we have to understand the barriers in order to overcome them. So we've been to 7 of our 10 cities so far, and by June we will have finished up all 10 roundtables, and then later this year we're launching a major initiative in those 10 cities to do something, not just talk about it in these cities, to get on the ground and to work with our community leaders to make a difference based on a model in Chicago where they still have terrible breast cancer mortality gaps, but we reduced that gap working with community organizations with $2.5 million that my organization put into the community in Chicago, Avon Foundation, another $1 million, but in 6 years, we reduced that mortality gap by 35%. That translates into real lives saved, actual lives saved, and we want to replicate those kind of results. And my goal for our organization is to reduce in those 10 cities the breast cancer disparities rate by 25% in 5 years. It's a bold goal, and people laughed when I put it out there, said, "You'll never get it done." Well, we've engaged a number of people who want to support that effort, so we are going to show that we will and can get it done. So I know that there's no single reason why we see these disparities. Everyone, when I talk about them, they say, oh, well, it's because of access to care, and oh, it's biology, and it's many, many things. And we have to address the problem on all those levels. The fact is that across our nation, African American women die at a rate of 40 times higher rate than white women of breast cancer. That is simply unacceptable, and we need to change that. But health equity goes well beyond achieving a system where everybody gets good care. So our goal is to assure that every person receives the individualized support and medical attention that they need to get the best possible health outcomes. And which brings me to what I'm supposed to talk about, which is breast cancer screening and primary care. Well, you know, you have heard from my ACS colleague that there's a lot of controversy about whether or not the right age to begin mammography screening is 40, 45, or 50. And my organization has taken the stance that we as doctors, need to have a conversation with our patients about what is the right screening schedule and time to begin screening for them. Because all of the guidelines talk about average risk. And guess what? People don't know if they're at average risk, and their doctors don't know if they're at average risk. And further, African American women, by definition, in my view, are at higher risk because African American women get breast cancer at a younger age, at a more advanced stage, and often more aggressive forms of breast cancer like triple negative disease. So it seems to me that we ought to rethink, particularly in communities like African American women, Latina women, where the outcomes are poorer, that we ought to rethink how we approach risk. So the reality is, though, that many of us, and I was a primary care doc right about 2 miles from here, and we really don't have the time when we see our patients to have that conversation, to do that assessment. These are constraints that keep us from offering the one-to-one care, the kind of care that we want to provide, we all want to provide for our patients, and the kind of information that can help guide patients to engage in that shared decision-making that we hear about. So I'll tell you about an experience that I had in my DC clinic, and what you can do when the opportunities present themselves, when you can focus on addressing the patient's needs rather than the needs of the clinic. I was working at a geriatrics clinic in DC, and we had a largely underserved community that we were taking care of. They were the sickest, the oldest, the most vulnerable patients. And my medical center director said to me, well, you're a primary care service, so you need to see in your clinic X number of patients per day. Well, you know, I took care of I actually took care of a World War I veteran in my geriatrics clinic, but mostly aging World War II veterans. And if you're taking care of a 90-year-old, you can't even get a person up on the exam table in 10 minutes, okay? And then they were saying, get them in and out in 15 minutes. Ain't gonna happen. So I went to my medical center director and I said, give me 6 months where you're not holding me accountable for the number of patients I see. And if you don't see a reduction in what you track, the costs of seeing these patients, their medications, et cetera, then you can hold me responsible. Well, guess what? We blew the goals right out of the water. We were successful because we used a team approach where patients weren't only seen by doctors, they were seen by a team. And I know that's hard to replicate in many settings, but we even went so far as doing home visits on patients who we thought were at greatest risk. There were many things that we found that were invisible in the clinic setting. We found loose throw rugs that people could trip on and break their hips. We found many times people were sharing medications in a household. Okay, my wife has high blood pressure, I have high blood pressure. Let's just use the same medications because we both have high blood pressure. And we found a number of dangerous situations. Several times when I went on home visits, I admitted patients to the hospital, and I lied about why I needed to admit them, but I lied because I could not, in good conscience, keep them in that setting because it was too dangerous for a variety of reasons. So we beat our goals by focusing on how we could best take care of our patients, not how many patients we took care of or how quickly. So, and guess what? Further, we were able to, because those patients weren't coming back week after week after week because their needs weren't being addressed, we were able to see more patients in that time as well as reduce costs. But it was what I wanted to do as the doctor for my patients. And what if we took a broader approach, a community approach to health care? What if we had this hand-in-glove approach where we had our patients connected in the doctor's office with those outside of the office? How many more people could we reach? Now, as part of our Disparities Initiative, we're talking with the communities, we're engaging the communities, and we're asking the communities to own the problem and be the solution to the problem, because we know that we cannot make progress in primary care, in breast cancer mortality rates, or whatever, unless there's trust in the communities. So we talk about of the community, by the community, and for the community, and that's how we are delivering our Disparities Initiative. We've invested a lot in patient navigation. Last year we got a grant and we have 16 national programs in patient navigation. Now, I'm not talking about nurse navigators in hospitals or clinics. They do a great job, but I am talking about community navigators, people who, well, when you go for an appointment or you miss an appointment, will knock on your door. We'll find the child care that you need for you to get to your appointment. We'll provide transportation, and will not let you go unattended for your medical needs when they have been recognized. So we've been working a lot with faith-based communities to get this done, and it's been part of the key reason why we were able to be successful in the work we did in Chicago, the work we supported there. And that's because when we know that a lot of people, we lose a lot of people, screening is great, so you have an abnormal finding, you don't have a diagnosis. So between getting that abnormal result, we lose a lot of people because they're scared. They don't want to know they have breast cancer. But we will not let those people go unattended. We will take care of them. We will guide them. That's what navigators do. They guide the patients, and they're with them every step of the way. So we were able to get that kind of guidance through our navigation program in Chicago, and we got people into for a follow-up for a diagnostic or clinical resolution or a cancer diagnosis within 60 days of having an abnormal diagnosis. And that made all the difference, because then those people and their navigators got them into treatment very, very quickly. So that we know that from time of diagnosis to time of treatment can make all the difference in your outcomes. We just funded a new program last year in Buffalo, New York, where their goal, the purpose of the navigation program, was to get people into treatment after a diagnosis within 60 days with personalized navigation services. So I think that, if we can link these systems and we can use the community as the heart and hands of the medical care system, we can make a lot of progress. So we have over 100 affiliates at Komen, and we work in almost every community. We have a little bit of white space, but we try to get to most communities in the U.S. And all those races you see? We have 153 races. 75% of the money that we raise at those races stay in the community for these kind of community support services. And I can talk to you about our treatment support services, our co-payment programs, our navigation programs, our child care programs, our transportation programs, because we realize that just providing mammograms is not going to move the needle. Not in the direction we need it to move anyway. So the bottom line is that we are all in our communities part of the healthcare team. We're all responsible for the women and men in the communities we serve, for equipping them with the best information and ensuring Not only that they have access to care, but that they have access to high quality care. And I know as a physician that each of us feels very deeply and very committed personal responsibility to the patients we serve. And the opportunities lie in matching the right connections, the right resources, and that making it simple and effective so that we reach, in concert with our community leaders, the goal to health equity. So thank you very much.
Thank you, Judith. Our next speaker is Dr. Hayden James McRobbie. He is the Professor of Public Health Interventions at the Wolfson Institute of Preventive Medicine, Queen Mary University, London, United Kingdom. Welcome.
Okay, thank you very much for that kind introduction and the invitation to come and speak to you. I'm going to be the one with a funny accent at the end, and I'm a New Zealander, and we tend to talk very quickly, so raise your hands in horror if I go too fast. Now, I've already had a very good introduction on one of the key risk factors for cancer, of course, and that is smoking. So I'm going to give you a little bit of practical information as well of how you might better help your patients who smoke. I don't want to spend too much time on the background because I think you all agree that smoking is a leading cause of cancer. And stopping smoking, of course, if you do it early enough, you can prevent the risk of cancer, or at least lower it. But even if you help people stop smoking who already have cancer, you can increase their survival time and increase their treatment responses. So there's never a bad time or never too late to stop smoking, even though some of your patients may think so. And I just want you to remember, just keep in the back of your mind, most people who smoke don't want to carry on. They actually do want to stop. It's not actually their fault that they find it difficult. It's not that they're weak-willed. This is an addiction we're talking about here. And there are a whole lot of other factors that go along with this. And if you've got mental illness, or if you come from a background where you've got a whole lot of other things going on, it is hard to change behavior. I also work in the field of obesity. So again, when you're trying to change behaviors like this, it can be tough work. Now, looking at tobacco control strategies, there are there are three legs to the stool. I'll show you the third one in a minute. But just to flag prevention, we must carry on with this. We have seen a decrease in smoking prevalence in young people in the US, as we have in many other countries. I do worry that younger people are just starting a little bit later than perhaps they would have. Cessation support, another leg that's important. Helping people stop smoking doesn't lower smoking prevalence, but it's a life-saving intervention. So why wouldn't you offer it? And then perhaps this third one to consider, which is always a little bit controversial, is harm reduction. So for those who struggle to quit or perhaps don't want to, there'll be a few of them around, do we offer them solutions that at least reduce the harm? Now, in terms of brief interventions, because this is what we can all do, and it doesn't matter which of these different mnemonics you remember, whether it's the 5 A's, the 3 A's, the 2 A's and an R, or ABC as we use in New Zealand, it's all the same thing. Okay, it's about screening for tobacco use and then offering support. But I want to get across to you that it's the offer of support that is the most useful. You probably said, you better stop smoking, you've got an increased risk of cancer in your family. That's sort of typical brief advice on medical grounds. What we should be doing is, look, I know that you smoke, I would really like to help you to stop, and this is what I can do. So it's their offer of support to change their behavior that will have their biggest impact of making a quit attempt. Okay, they want to know, they know you care, but show you care by making an offer of that help to quit. So it's their offer that changes the behavior change. Now, how do you make that offer? I know many of my colleagues would say, you smoke, do you want help to quit? It's not exactly the most exciting way to offer something that most people don't think they need anyway. So, you've got to make it amazing, special. This is a one-time only offer. This is what I can do for you. And I think there are going to be many areas of health behaviour change that we need to get a little bit better at making these offers of support. So, encourage them to do it. Say, look, it doesn't matter how many times you've tried before, you can still do it. You can get there. Briefly explain the options. Okay, you don't have much time. But if you know something that's working well and within your area, then just get people to it. And make it emotionally salient as you possibly can. I had a GP friend of mine who said to one of his young patients, you know what, I just had a young woman not too older than yourself who I just diagnosed with lung cancer. I don't want that to happen to you. I'd really like to help you stop smoking. And this was a young woman that had never wanted to quit before, but suddenly it was relevant to her. So keep those stories perhaps in the back of your mind and then help people access it today. And it's not as though we don't have anything to offer. I know we don't have any magic cures for helping people stop smoking, but at least there are some things we have in our toolbox. If you just look at the pink bars on that graph there, which have just disappeared, you'll see that a combination of stop smoking medicines and support has the best effect. Now, these are from the New Zealand guidelines for helping people stop smoking, and you can see that we use nortriptyline in New Zealand. It's considered second-line therapy here in the US. We use it because it's cheap, and we have a health system that, of course, likes to run things as cheaply as possible. In terms of behavioural support, we don't all need to be psychiatrists to deliver this. These are the top 5 evidence-based behaviour change techniques. These have come out of the UK. And you can see some of them, of course, that but you don't need to build rapport because you already have rapport with your patients. But just simply giving them some information on how to use the stop smoking medicines, getting people to understand that go into this, do everything you can not to have a single puff. That's pretty much the basic advice that we use in a lot of our practice. Do whatever you can going into this not to have a single puff, and you'll get there. It's going to be a bit hard to start with, but over time it will get easier. Now, ideally, we want people off combustible tobacco and not using nicotine either. So from combustible, which is the harmful thing, to nothing. Just to remind you, it's not the nicotine in tobacco smoke that causes the harm. It's everything else. Long-term NRT use, for example, nicotine replacement therapies, is associated with almost no known risk. There are some theoretical risks of nicotine, but they haven't been realised in human trials or human follow-up. Now, that's not always possible, and so sometimes you have to get people onto nicotine use for a while before they come off that as well. Now, usually that's a sort of 3-month period, but for some people it's a little bit longer. So I'll have some patients that are using NRT for a year or so. And then some of them might actually carry on using nicotine long term. Some people are going to use combustible tobacco and nicotine, so the sort of dual use. And then they'll either go to nicotine use only, and then they'll either stop that or carry on using it. But there are probably going to be a small proportion of people that use both longer term. Remember, the benefits of smoking reduction are not that great. The key message here is aim for complete abstinence. Get off combustible tobacco completely. If people have to use nicotine for a while to help them to maintain that, then I think that's okay. Now, I just want to very quickly cover electronic cigarettes because they're sort of the popular, or the topical rather, at the moment. We started looking at these in our research unit about 9 years ago now. When they weren't very good, they were sort of the cigar-like devices on the left of the screen there. When we talk about electronic cigarettes, there's not just one product. There's a whole different range. They all differ in the way they look, the battery size, the power, and the way that they deliver nicotine. Traditionally, these weren't produced by tobacco companies, but I know now a few tobacco companies are getting involved in these. They do, at least the good ones, when in the hands of experienced users, they do deliver nicotine. This is pretty good nicotine delivery from this particular device. This is a tank system, and these were experienced users. I have seen peak plasma concentrations higher than this, up around 30 nanograms per mil, so much more what you'd see with a traditional cigarette. Do they help people stop smoking? Well, these are data from the Cochrane Review, so meta-analysis. There are only 2 randomized controlled trials at the moment that have been carried out, but combining those, so just looking at the top table, there is some evidence to show that e-cigarettes compared to placebo e-cigarettes, i.e. ones without nicotine in, do help people to quit smoking long term. But the strength or our confidence in that is not strong because there are only 2 studies at the moment. There's some sign. There are more studies going on at the moment, including one we're doing in London. Toxicant exposure, we're always trying to estimate, well, how much safer are these things than smoking? The general consensus is that these are safer. Exactly how much safer is all debatable. So Public Health England estimated that they're around 95% safer than smoking. This is probably, they're probably closer to sort of 97, 98% safer than smoking. But we don't have data on long-term risks yet. Okay, because no one's used these long term. We're all looked to the UK and the US where these things have been used for some time now. So risks may yet emerge. Okay, we just don't know. But for people who smoke, those risks are going to be less than smoking. For people that don't smoke, that use e-cigarettes, obviously there could be an increase in risk. So we don't want people that don't smoke using these devices. Just interestingly, just a last slide here, perception of harm. It's interesting to show that over time, if you just look at the equally harmful, so these data are from ASH UK, over years, 2013, 14, 15, the public perception of harm of these devices has been going up. More people are thinking they're equally as harmful as smoking. And I think that's misinformation that we should probably try and do something about. Making sense of the evidence. This is useful. It's a useful guide. We've produced it as a co-author on this in the UK. And it was really to summarize the evidence and trying to give some practical advice for people, for practitioners who help people stop smoking. Because we're all confronted with people that say, hey, doc, I've got this. What do you think? And we can't say, oh, I can't talk about that. We have a duty to say, look, well, this is what I do know about these things. So in summary, just to go back to my main point, we've still got to get better at systematic screening for tobacco use, documenting that, prompting quit attempts. People can't quit if you don't prompt them to do so. So making that offer of support to help them quit is certainly important. Some smokers, especially those that have tried everything in the past and perhaps those that are really highly dependent, we may need to consider longer-term nicotine use to help them stay off the most deadly nicotine delivery system, which is combustible tobacco. And I think we'll see lots of these new products in the future, and we're going to have to find ways of looking to see if and how, or how and if they might fit into our routine clinical practice. Thanks very much.
Thank you, Hayden. Dr. Brawley is unable to attend today, so we will continue with our panel discussion and questions from the audience. When I was a fellow, I ran a drug rehab clinic and found quite a few people that I knew from high school in the clinic on heroin and cocaine. I could help them get off heroin and cocaine, but I couldn't stop them from smoking. Truly an addiction that embodies everything that we've ever learned about addiction and the principles of addictions. Questions for our panel? Yes.
Been accused of avoiding the issue of environmental health, especially the American Cancer Society, where you started out with that initially decades ago and then you veered off into just treatment, early treatment and early detection. Are you being forced in that direction, or are you going to say also it's an issue of money? Because that was your initial goal when you first formed. And can you address some of the issues of the increase, causes of the increased prostate cancer in black men?
Yes, first of all about environmental health. We're seeing cancer predominantly as not all cancer, because personal genetics and accidents play a role, and there has been some scientific debate of what percent of cancer is just your risk and accidents of mutation versus preventable and environmental influences. But actually, the latest research that was just published, still being debated, is that actually more than half is a function of our environment. So the ACS has never moved away from looking at environmental influences on cancer risk. But we have prioritized the biggest environmental influences, which are the determinants of tobacco uptake, the determinants of exercise use, the determinants of nutritional intake, and in fact, have a major initiative now on healthy eating, active living environments to try to create those healthier factors. Our intramural research program has again never moved away from looking and evaluating environmental causes of cancer, and we're involved all around the world with IARC and with NIH at looking at the environmental determinants of cancer, and we encourage you to take a look at the information that we're providing on our website about specific environmental determinants of cancer. The final point, and it's not a dollar issue per se. I think it's a resource issue for all of us that tackling every environmental contributor to cancer is very, very difficult. But identifying those big environmental trends, such as we've seen in Flint, Michigan, which may not be a cancer issue, but a very major trend around health, remains a priority for us, and we will intervene there. Why African American men experience such a high risk of prostate cancer is not fully known. It is a phenomenon in part of an interaction of not just being African American, because African men are not as high a risk. So there is this interaction again with the United States environment that has contributed to this. Clearly, dietary factors, exercise factors, we need to continue to examine and look at. The good news is we've seen a dramatic decline in mortality rates. Whether that's all due to PSA screening and whether we're going to now start losing some of that progress as PSA screening is declining is something we're going to have to watch really closely.
Good afternoon, and thank you to the panelists over to this side. Oh. Neva Lubin-Johnson from Chicago, and thank you all for your presentations. A couple of questions related to cancer prevention more so, and screening, one to screening. And that is not just environmental health, but in your internal environment and diet. Is ACS going to talk about, a more plant-based diet in terms of decreasing cancer rates, since we know that does occur, in addition to it helping with controlling cholesterol, diabetes, high blood pressure. And then the second thing is, in terms of colonoscopy in African Americans, American College of Gastroenterology has said screening for African Americans should start at 45. And why hasn't ACS, weighed in on that? And then to your slide about the underestimation of what prevention does, do you think that's contributing to the United States Preventative Task Force decreasing screenings in, several cancer areas?
Yeah, thanks. I'll see if I can tackle all three, and I'll try to do it really quickly. So the Cancer Prevention Study 2, which is a cohort study of hundreds of thousands of people that ACS conducted, was the first study in America, or the most powerful study showing the link between what we eat, what we weigh, and cancer. And one of our 6 national priorities is healthy eating, active living. And again, I'll just leave it at that. Happy to chat with you more about and hook you up with our leaders for that. We just added a leader for healthy community initiatives. What we are moving not away from, but we're adding is moving beyond a focus of just eat better and exercise more, because that alone is not going to solve this problem. We really need to create healthier environments. So the second question was, the third question I remember, you'll remind me on the second. The third was, do I think that the issue about randomized trials has contributed to the task force's view? I think the answer is yes. They actually place less value. They look at observational data, but place somewhat less value on observational data. So I do believe that there's been some overweighting of the randomized trial data relative to the others. And I'm sorry, the third was... Oh, yeah, it's really a dramatic trend that colon cancer death rates are dramatically declining from 50 on up, but unfortunately they are rising, and this is not just in African Americans, they're rising in European descent individuals as well, under 50. So you see this rising mortality rate from colon cancer. You hit 50 and now it's coming down due to screening. We're in the midst of re-looking at our guideline this year. We also responded to the task force's draft guideline. We will be looking really carefully at the interaction of age, the interaction of being African American, European descent in our new guidelines. So stay tuned.
Unfortunately, I have my marching orders. Let's give our panel, outstanding panel, another hand. Thank you so much. Dr. Mitchell.